the usual approach that we follow to assess our patients' fall risk. And then, as Kate said, based on about 2 to 3 months of experience, where we had to suspend in-person visits with patients and shift to telemedicine for these kinds of assessments. I'm going to use, share some kind of just thoughts and strategies. This is not evidence, this part is not evidence-based, it's experiential. So a disclaimer there. I think we're learning as we go. So first, this topic is fall risk assessment. So I wanted to just ask you all a few questions so I have a sense of where you're at in terms of your understanding of what this term even means. So I don't have a formal poll set up, but wanted to just see with maybe a show of hands from y'all, if you could just say, raise your hand if you're familiar with the concept of fall risk assessment. Okay, I see some people raising their hands. I'm confident that I can conduct a fall risk assessment with my patients. And I'm seeing a few of you tile, but there's more people than I can actually see, and some people without cameras on, so I can't tell what you're saying. But and then the last thing is, are you actually doing this? Are you conducting fall risk assessments with your patients? Raise your hands if you're doing that. Okay. So it looks like people are familiar with the concept. Probably fewer people are confident and actually doing this. So with that, just to launch in, we'll talk about some this in general before we jump into the telemedicine delivery of this care. But first, just a few key facts about falls. First, falls are really common as people age. It's important, though, to realize that falls aren't really a normal part of aging. So they're not inevitable and often preventable. We know that from research. And second, we know that they are the cause, in fact, the #1 cause of injuries, both fatal and non-fatal, and a certain proportion of those results in serious injuries, such as fractures or head trauma. And these injuries are often very costly to care for, and the most recent estimates suggest that it costs our country about $50 billion every year to care for injuries that result from falls. And data over the past decade shows that both ER visits for falls and deaths due to falls are on the rise. And really importantly for us as healthcare providers, we need to understand that patients are, our older adults are very unsure about discussing this with their doctor, and data suggests that only about half, or not even half, actually do discuss it with their physician if they're falling. Just so we're on the same page about what do we mean by a fall, the term fall might mean different things to different people. So the current generally accepted definition of a fall is coming to rest unintentionally on the ground or lower level, and not as the result of either an acute health event like a stroke or a seizure, or due to external forces that would cause anybody to fall. For example, if you were pushed or shoved in a crowd. So basically what we're talking about here are falls, are events that result from slips, trips, stumbles, or loss of balance. So like other conditions that are associated with aging, like delirium or dizziness or incontinence, falls are classified as a geriatric syndrome. And what defines a geriatric syndrome? In addition to the fact that these syndromes are age associated, a hallmark of all of them is that they are usually due to multiple contributing factors. And that understanding of the nature of falls leads into very naturally into the way we approach thinking about them. So why do falls actually happen? they result from the interaction of an individual with his or her environment. And so it's important to understand that even though many people think about falls as purely accidental, thus not preventable due to purely environmental causes, that falls actually result from factors that are intrinsic to the individual, especially if they're occurring repeatedly. So when somebody's falling repeatedly, we need to really think about and also take that as an opportunity to educate our patients about the fact that there are probably some things that they can't help, that maybe are age-associated acquisitions like changes in their vision or hearing, or chronic pain or chronic conditions that are part of their makeup that are factors in their falls. We can think about these risk factors in a couple of different ways. So one way is this sort of intrinsic, extrinsic dichotomy. Another way is whether or not these are, you know, in a sense, modifiable or fixed or non-modifiable. So for example, if somebody has Parkinson's disease, at least at this point, we don't have a cure for that. So that would be an example of a non-modifiable risk factor. But by contrast, medications that people take could be potentially modified. So the randomized trials of fall prevention interventions have focused on the subset of risk factors that are potentially modifiable, and the findings from that research have informed our current clinical approach to falls and their prevention. And that is what we refer to as fall risk assessment and management. So where do we start with our approach to falls? So the first step is actually screening our older adults. And unlike some other types of screenings where we might do a test or a study, you know, for example, with screening for breast cancer, we obtain mammography. For falls, screening is simply asking 3 key questions that are shown here. Have you fallen in the past year? Do you feel unsteady when walking? And do you worry about falling? This algorithm that I'm showing here summarizes what to do when you ask those questions based on the answers that you get. So first, looking down the left-hand side, for someone who says they haven't fallen or they've experienced just one fall in the past year, and they are not endorsing any problem with gait or balance, then this is the realm of primary prevention, where we should still be encouraging people to adopt, if they aren't already practicing, strength and balance exercises, and helping them understand what other things might be things they could think about that could contribute to falls in general. By contrast, if the person says, yes, they have fallen, and you ask them, how many falls have you had in the past year? If they're endorsing that they've fallen more than once during the past year, or they've been for a single fall to seek medical attention, or they're endorsing a problem with their walking or their balance, this is where we need to do further assessment. That is the kind of the nuts and bolts of what we'll be looking at next in more detail, is that assessment and management, the so-called fall risk assessment. I should note a couple of things here. This guideline suggests that the assessment of gait or balance should be done in a clinician's office. So hold that thought. So in addition to asking these questions, we should be examining gait and balance. So we'll look at that a little bit more in depth in just a minute. So the modifiable fall risk factors that have been tested in intervention research and been shown when addressed as a package or a group altogether and found to reduce, those are listed here. So in essence, it's strength and balance deficits, postural, also called orthostatic hypotension, medications, in particular medications that affect brain function, so-called centrally acting or central nervous system active medications, issues with people's feet or footwear, vision issues, and environmental factors. And for the most part, the environmental factors that have been examined have been home, in and around the home. So just a quick break, because I'm going to transition now and talk a little bit about how can you actually do this type of assessment over using virtual means. I'm just interested in how many people have been conducting virtual or non-in-person visits with patients since COVID hit. Yeah, quite a number of people. And then what about with older adults specifically? Have any of you been doing virtual visits with older adults in your practice? Yeah, I think having the perspective of doing this with older adults is really helpful, because there are some factors, that to consider that have come up in, I think, other presentations that we've had as part of the ECHO platform, such as sensory deficits, for example, where people have issues with hearing that add an extra layer of complexity to doing these visits. So where to start with these visits? The first and really important point that I want to make is it's critical to get prepared to actually have a successful visit with the patient. We had a number of visits early on where the patient did not understand that we were actually going to be using the computer and a virtual connection. So they would agree to it, but that wasn't something that they were prepared for. So making it clear and that this is going to be a technology-driven appointment, and making sure that the patient actually has the necessary technology and is able to use it ahead of the visit is a key to success. And then what we eventually did was establish a workflow where the medical assistant would room the patient virtually. So about 15 minutes ahead of the scheduled visit, the medical assistant would contact the patient by phone and then help them get logged into the computer and into the virtual platform for the visit. And then having the patient seated in a chair that's stable and have their assistive device if they use one nearby, so that you can use both of those, the chair and their assistive device if they have one during your assessment. Having a family member or caregiver obviously is helpful if there is one available. Many of our patients, of course, were without those, and that was one of because of limitations on COVID, where family were not coming over. So oftentimes, and I'll speak to this in just a couple minutes, the visit would need to be done by phone if we had issues with the virtual connection. But if there was a person who lived already in the household, having that person assist with the camera, being able to move the computer and the camera around during the assessment is very helpful. The assessment really is pretty straightforward if you can get the connection and the patient is able to interact with you in that virtual milieu, so to speak. So we can still ask about their most recent fall using this mnemonic to help us remember the aspects of the history that we want to take. Asking them about if they have an assistive device, and if so, how are they using it, having them describe that to us, and then getting honed in on those modifiable risk factors. So asking them about, are they doing any balance or strength exercises? Do they feel dizzy when standing? Do they have any problems with sensation in their feet or any pain? What kind of eyeglasses do they wear, if any? And then one of the great things that we discovered is that some sort of silver linings with these visits is whereas many of the patients would not bring their medications to clinic and we'd be uncertain as to exactly what their current regimen was, we could have them go to their medicine cabinet, pull out their pill bottles, and read the names of the medications off to us. So we had a clear understanding of what they were taking, and they could tell us how they were taking it as well. Then in terms of the exam, very focused on the things that we could do visualizing around the patient in terms of their gait, their balance, their lower extremity strength, looking at their feet. If they happen to have a blood pressure cuff, having them check a blood pressure, and a poor man's measure of orthostatic hypotension, which is standing blood pressure, to make sure that the blood pressure isn't too low, is one of the things we could still get if the patient actually had a blood pressure cuff. And then the environment of the home, we had a direct view of it. So we weren't second-handing that part of the assessment, which was really nice. It was a real-time view of it. And we could also ask them to pull out what they usually wore on their feet in the home. So we asked them, can they stand up from their chair that they're seated in without using their arms? If they could do that, then we could still ask them to do this test called the 30-second chair stand, which assesses lower extremity strength. As far as balance, we could look at a couple of aspects of balance that we like to assess, both standing still or so-called static balance, using this test called the 4-stage balance test, which is 4 different progressively more challenging foot positions. And then some dynamic balance or moving balance. Again, not the formal test that we would do in the office necessarily to assess dynamic balance, but still give us a feeling of how much difficulty they would have moving, maintaining their upright posture. And the links to the YouTube videos demonstrate each of these assessments. With the watching them walk, if this was where the family member or caregiver came in particularly handy, having them holding the camera so that the patient could be followed while being observed. And then if they were using an assisted device, looking at that device, is it fitted properly to them? Does it look like it's providing the right amount of support? Is it worn out or brakes damaged if it's a walker, for example? And if it's a cane, are they using it in the proper hand? And then, as I mentioned, it's a real bonus to be able to get the window into the patient's home environment, something that we don't usually get. So this was another silver lining with these assessments, was we could actually firsthand observe different parts of the home and the patient navigating it. In terms of addressing whatever aspects of risk we identified through these assessments, again, focusing on these areas that we were still able to assess, we were able to make some recommendations and still really encourage engagement around the things that they could change that we had identified. And encouraging exercise, strength and balance exercise, because this has been shown to be the single most effective approach to preventing falls and injuries. And it's very important for our patients to understand where to focus their energies. And because of resources these days that have been mounted online, there are actually some evidence-based resources, including a form of Tai Chi called Tai Chi Moving for Better Balance, that has strong evidence for benefit for fall prevention, as well as the National Institute on Aging's Go for Life routine, which is another self-guided routine, which includes components of strength and balance as part of it, and was developed by a geriatrics fellow long ago and far away now. So has good exercise geared towards those components that need to be practiced to prevent falls. And then much of this assessment is, and management has to do, at least with that initial assessment, counseling people. Most older adults don't understand that medications can contribute to falls, for example. So that's still something that we can counsel them about and help them make decisions with us about how to address reducing that aspect of their risk profile. Making sure that they have some self-management strategies available that they can practice if they are having dizziness when they change positions. And then the home safety checklist from the CDC is fairly self-explanatory and is another nice resource that we could pull off the web and mail to the patient or send as a PDF depending on their preference. So for those patients who have no, not the necessary resources, whether they have no internet connection, they don't have a computer, they're not equipped with the technology, what about just a phone visit? How can we approach those? So just a couple of words on that before I close. We have done some recent research, some colleagues and I, looking at the utility of self-report questions. Again, some of these key questions, and have found that self-report questions are actually very highly correlated with performance on tests of gait strength and balance. So what does this mean? When we're limited to the use of a phone in a telephonic visit with our patients, just asking them whether they feel steady or unsteady when they're walking, whether they can stand up from a chair without using their arms to push up, and if they are afraid of falling, can be useful to identify respectively a balance problem, a lower extremity strength problem, and help guide our recommendations for them. So really these are important ways in which we can actually continue to provide care to our patients in the time of COVID, despite not being able to interact with them in person.